Hit record, okay. And then I'm going to record just the webinar part of it, because I find that even when people aren't on, you know, they might want to watch it at a certain later date. And so I want to give them that opportunity. All right, so first I'm going to just tell you a little bit about who I am and just describe a little bit about why I'm actually talking about this. You might wonder, why her? So a little bit about me. So I did my undergraduate work at Princeton University. I did my law work at, we were talking about that a little bit beforehand. I did my law work at St. John's University School of Law, and my focus was in healthcare, public health, and bioethics. From there, I went to Harvard University School of Public Health, and I was in a law and public health program with 9 other lawyers, and we specifically focused on public health law. And then from there, I went to Teachers College, and my focus was on adolescent education, and also in basically sort of media and communications, okay? I'm currently a public health law professor, so I teach at Long Island University. That's where my main appointment is. I also teach at Columbia University and at St. John's University School of Law. So what I thought we would do would be to first just get some definitions going, which hopefully this is all not new to you. Hopefully you've heard this before, but usually there's at least a couple of terms that people have not heard before. Then we'll go into generalities regarding COVID-19, and then we'll talk about public health law generally, and then a specific case for New York, which comes to us today from Governor Cuomo. So I thought it would be very timely. And I watched his entire press conference from today and took copious notes and did some research in terms of some of where we are in real time. And so I have added that to our PowerPoint, and hopefully that'll be helpful. And then we will take some questions. So I will try to get through this as quickly as I can so that we can leave at least 15 minutes for questions. All right, so COVID-19, as most of you probably already know, it's called COVID, which stands for coronavirus disease, COVID, and it is a respiratory illness. It spreads from one person to another, and it was first identified in Wuhan, China. But wait, what is a virus? So a virus is a biological agent. And essentially why a virus is so challenging is because it infests itself within a host cell, and then it replicates over and over and over and over again. And that's how people get sick, because then the virus, it's the identical, well, almost identical copies of the original virus, replicate themselves over and over again. And that's how people end up getting sick. And we've probably all seen this image before. This is the actual virus itself. Okay, so social distancing. We've heard this term a lot too. What does it mean? Social distancing is a public health practice that aims to prevent sick people from coming in close contact with healthy people in order to reduce opportunities for disease transmission. It can include large-scale measures like canceling group events or closing public spaces, as well as individual decisions such as avoiding crowds. So obviously, we are all currently in the process of doing social distancing. And there's a great article in the New York Times, which I will make available to you, that talks about the difference between social distancing and social isolation. And I would say that some of us are currently feeling as though we're not only engaging in social distancing, but social isolation. And so to the extent that we can stay a certain amount of distance away from people and not go to large meetings and concerts and so forth, but we can still stay connected with people, that's one of the things we'll talk about. And it probably is one of the things that has been leading to a decent amount of sadness, depression, loneliness in people, because they feel very isolated, not only socially distant. And as I heard somebody say the other day, we really want to work towards physical distance, but not necessarily social distance. So we should probably be saying physical distance, because social distancing is something that really probably more so leads to isolation. So we want to work on avoiding that. Why is social distancing important? It slows down the outbreaks, and in this particular instance will slow down the spread of COVID-19, reduce chances of infection to high-risk populations, and we're going to talk about that when we get to the part that Governor Cuomo was talking about today, because there are some very clear high-risk populations that we want to protect throughout this. Reduces burden to the healthcare system and to healthcare workers, and flattens the curve, which essentially means that for our purposes, the concern is that we're going to have spikes in this illness, and we're already hearing about shortages within the healthcare system. So we want to avoid those by flattening the curve. So this is what the curve looks like. The first one is more spiky in nature, I would say, and that's when we have uncontrolled transmission. And the second one is a more even, I would say like a rolling hill, so to speak, where we have more control measures, okay? So what we want to do is get more to the even blue line, and we can only do that where we have controls in place. It's not to say that we won't still have a decent number of people who become ill. We will. But if we can have that number and still maintain some equality as it relates to what that looks like, that's definitely the goal, and it's what we are striving for, okay? Right, yeah, and if I say anything that doesn't make sense, please let me know and I will go over it. I'm happy to do that. Okay, so quarantine versus isolation, that's the first term we got to deal with. And again, by now, hopefully you've heard the difference between the two, but I've heard a lot of people use those terms interchangeably. So let's talk about what that is. When you are sick, when you have a disease, when you have, hopefully nobody has it, but when you get, if you get COVID-19, that would mean that you would be in isolation. So people who we know to have a contagious disease are separated from others and they are in isolation. That is very different than a quarantine, which restricts the movement of people who are exposed to a contagious disease. So if you had contact with somebody that traveled to Italy a week ago, or if someone known to you actually was swabbed and was diagnosed with COVID-19, you might be told that you need to be put in quarantine. And that measure is for people who actually have not gotten the disease, but have been exposed, okay? So those are how those terms should be used. Myths, there are a lot of them. It's summer, when it's summertime, we won't have to worry about coronavirus. That is unclear. If I wear a mask, I will be safe. That is not true. Only older people are getting sick. Boomer remover, which I saw on Twitter. It's just a horrible term. Not true. Other myths, we can talk about that possibly on future webinars or at the end of this webinar. If people don't agree to compulsory isolation, what, if anything, can the government do? The government can do a lot. And we're seeing that happen in real time with respect to the governor and what he is doing. So people can be told to stay in their homes. People can be told that they can't go to work, which just happened today in terms of basically everyone in New York. There are lots of things that can be done. And it's done in no small measure to protect people. Some people are not able to necessarily, we were talking about this before we started, they're not necessarily able to really comprehend on a level that is conscious for them what's going on. And so if they're using methods of denial, then we have to potentially help them with that. Infectious versus contagious disease. Infectious diseases are any disease that can be transmitted to a human being by means of a virus, bacteria, or parasite. It must actually infect the person. A contagious disease, diseases that are infectious and pass from one person to another. That's what we have now with COVID-19. It is a disease that we now know passes from one person to another. And we can talk at the end about what we sort of are learning in terms of how that happens, but we know that to be true. Outbreaks, epidemics, pandemics. So an outbreak of a disease is a sudden increase in the number of cases, and it's usually localized. So think the Williamsburg measles outbreak, which you could call it an outbreak, you could probably call it an epidemic. Somewhere between those two is what it is, but definitely somewhere between an outbreak and an epidemic is what that is. And then a pandemic is an epidemic that has an impact on multiple countries. It's global. So think COVID-19, multiple continents, multiple countries. It's pandemic, it's global. So I downloaded this from the World Health Organization about an hour ago. It's already outdated, I guarantee you that. But this tells us the number of countries with cases, and it's basically every country in the world. I mean, even poor little Greenland has 2 cases. So when we think about, are there cases in the United States, which maybe people are unaware of that? Yes, there are. There are cases in the United States, and there are cases all over the world, just about every country. How does COVID-19 spread? So originally, its origins were animal in nature. We now obviously know that people can get COVID-19, and also people basically can get it through droplets, respiratory droplets. Although there's some evidence that there are potentially other ways that people can get COVID-19, which are being researched, but this is a way that we know it to be true. We know this is the case. What are the symptoms? Fever, cough, shortness of breath, and others. And I put a link here so you can learn about more of what those symptoms are. How can individuals protect themselves? Avoid close contact with sick individuals, avoid touching. We've heard all these before. If you're sick, stay home, cover your nose and mouth when you sneeze or cough. Okay, so now we're gonna get into the public health law implications of this. And again, I think this is important because, I mean, one of the things that I've heard repeatedly is, oh, well, the federal government can't do this. The federal government can't do this. The mayor can do this, but the governor can't do this. So we're going to dispel all those myths and talk about what is a reality. So first, the 1918 influenza pandemic, and it spread worldwide between 1918 and 1919. It impacted about 500 million people, a third of the world's population at the time. There were 50 million deaths worldwide and 675,000 in the United States. We can avoid another 1918 by all doing our part from a public health standpoint, but also a public health law standpoint. We're going to get into that in a minute. What is a public health emergency? Well, it's something that involves the health of the public. That's all of us, right? So it's not just me going to the doctor for my specific illness, but it's the illness that all of us are potentially faced with. And it's an emergency. So it's something that is time sensitive, critical, can endanger lots of people. In this country, we use something called the utilitarian model to look at public health. That's the good of the many versus the good of the few. And that's how our laws for public health purposes are written. And that's what you're seeing a lot of over these last couple of days. The civil liberty interest juxtaposed with public health issues and public health interests. Compulsory powers. So this has to do, this is from an article by a very learned professor named Lawrence Gostin. He talks about within a balancing the public health and civil liberties and how we do that. So this is one way to think about it, this multi-pronged approach. And it looks at a few things. One is individuals must pose a significant risk of spreading a dangerous infectious disease. Number two, interventions must be likely to ameliorate the risks. Number three, the least restrictive means necessary to achieve public health objectives are required. Next, use of coercion should be proportionate to the risk. And last but not least, assessments must be based on the best available scientific evidence. So we'll think about these as we get to the specific example of New York and the public health laws that were put in place today. Emergency powers that the state can institute. There are a lot. We've seen some of them already. Banning non-U.S. nationals, evacuations, quarantines, suspending flights, recalling non-essential personnel, travel warnings. And there are others, but they are a lot in nature. Can the government tell me to stay at home, not go to a basketball game, or stop me from getting on the subway? Yes, yes, yes. The government can do all those things, and Governor Cuomo basically did all of those things today. Why should we care? Because the public health is not just about our own health, but it's about the health of all of us. We protect ourselves by protecting others, and we protect others by protecting ourselves. Federal powers and the health of the public. So as I'll talk about in a moment, from a legal standpoint, when we think about public health, usually we think about the states, New York, California, Mississippi. We think about states and what they can do, because that's where the bulk of public health law comes into place. And as I've mentioned to my law students, there was this thing fought 150 years ago, more or less, called the Civil War. And out of that, we created a federal government that had certain distinct powers, can tax, can spend, can regulate interstate commerce, with the rest of the powers being regulated to the states. And so the federal government does have the ability to control things like commerce, the commerce of between states or between the United States and other countries. An example of that would be, health of immigrants, for example, or visitors. There's also something called the Necessary and Proper Clause, which is sort of a catch-all. It allows the federal government to create certain laws that are specifically tailored. And then taxing and spending. The government can tax you, which, by the way, the tax deadlines have now been pushed back to July. So the government can tax you, and they can spend the money that they actually get. And also there are executive orders. This also applies to states, but the federal government, and specifically the president, can put in place executive orders to ensure that public health is safeguarded. But these are the basic powers that the federal government has, and they are decently prescriptive. So they are very clear in what they are. Civil liberties and the right of privacy goes back to a case called Jacobson v. Massachusetts. And that involved a man named Jacobson who did not wish to get the smallpox vaccination in the late 1800s. He refused to get it and was fined $5, which by today's standards would probably be about $100. The authority of the state, and in that case, technically it was Cambridge, Massachusetts, but the case ended up being a Massachusetts case. The ability of the state to do that is something called police power. And in that instance, Jacobson argued a liberty interest, invasion of his privacy. And the court stated, this was a Supreme Court case. We know that because of the citation, 197 U.S. 11. I'm not going to get into law school 101, but basically, we know what cases are and what courts they're in by the citations. And so that citation there tells us U.S. or SCT, depending on what legal research function you're using. that tells us it's a Supreme Court case. The court stated the liberty secured by the Constitution of the United States to every person within its jurisdiction does not import an absolute right in each person to be at all times and in all circumstances wholly free from restraint. So we have civil liberties, but they're only in as much as they don't impact on other people. So police power states and localities, a power promoting the public welfare by restraining and regulating the use of liberty and property. And states can't exercise the power relinquished by the federal government and specified in the Constitution. So the states can't override what the federal government can do, but the states have a lot of power in terms of protecting you and making sure that you're safeguarded and making sure that you're not endangered by someone else. And the states cannot infringe on the rights of individuals to the extent that those rights are protected by the Constitution, but they have a lot of power. What is the state's interest in the public health? Well, states are interested in protecting people from some external danger. COVID-19 is definitely that. People also have an interest in advancing overall interest of the state. And they have an interest in protecting people from their own poor decisions, which we will see in a minute in the New York example. Okay, so New York updates. So I'm gonna go through these updates kind of quickly, and then I'm gonna leave a decent amount of time for questions. All right, so New York updates. First, I'm gonna give you some numbers, then we're gonna talk about pause, and I'm gonna juxtapose that against what we've already talked about in terms of how it relates to the state laws that I described, and specifically the Jacobson v. Massachusetts case that I talked about. So, as of today, what are some of the things that New York is doing? So one of the things that New York is doing is they're looking for more beds. So if some of you notice, and see, here's the thing with something like a pandemic or an emergency. We usually have clues about things before we actually know what's going on, but the clues can be helpful. So, a few days ago, and in some cases a little bit more, some of the colleges started to shut down and they started to ask students to move out of their dorms. Well, why is that important? That's important because according to Governor Cuomo today, these same schools might actually be activated for purposes of utilizing those beds for people who will need them when we don't have enough space for people in the hospital. So where are these places? Javits Center, Hunter, SUNY Purchase, the place I teach, St. John's is one of these places, City College. So they all potentially will be freeing up dorm rooms and other spaces in order for people who are sick to be able to utilize them. In addition to that, there's a possibility that hotel rooms might be used for that same purpose. So we might use hotel rooms in order to put people either under quarantine. So people who've been exposed, but they don't have the disease yet, they might be put under quarantine, and we might use those hotel rooms for that very purpose. So the governor has been looking for people who are willing to help, and here are some examples of willing colleges. In addition, ventilators. So there's a deep shortage of ventilators, and what we know to be true in terms of the need for ventilators versus what is available, there's a pretty deep divide. And so the governor's office is putting out a call for entities, health departments in the state that have additional ventilators that they are not using in order to be able to make them available for this. And so another thing that is becoming a real issue in places like Italy, for example, is the lack of ventilators and the fact that there is a need for them. And this is going to translate into our current situation with respect to potentially a lack of ventilators here in New York specifically and throughout the country generally. These are the numbers as of today. Now, the governor made a really good point, and I'm gonna reiterate it here. The numbers in New York look stark. So the next closest state is Washington. Now, one of the things that he mentioned, and I think we need to keep in mind, is New York is being pretty diligent now about testing. And so one of the things we have to question is, are the numbers this high because of all the testing? With another sort of sub issue being, well, given the fact that we extrapolate from other places, from other countries, that they had really high numbers and those numbers went up and up and up. Is there a possibility that there are more people who are infected and we don't know about them? With, I think, probably everybody in the call probably saying to yourself, yes, this is probably the case, and you are probably right. And so the cases here, in terms of the number of cases, I mean, basically what that tells us is that it's a number in time relative to who we know to actually have the disease. And then we can extrapolate from that there's probably lots of other people that have the disease and have not been tested or has not manifested itself in them, which is another issue, which has to do with how people exhibit the disease and how we know when people are ill. And that is something that is not completely clear. And it would appear that there are individuals who can be ill for a certain amount of time before it is clear to us that they are actually ill. So again, when we talk about social distancing, a real reason why that's important is because they, we don't know necessarily if they are ill and they haven't been tested. Yeah, I saw a question about, someone who's in East probably has the disease and won't test her, no real tracking of this until everyone gets tested. Yeah, kind of. I mean, there's clearly tracking because we're looking at it right now, right? So there's tracking of what we know to be true. My sub area of interest and what so when you're in public health school, by the way, does anybody actually know what public health is, like public health school is? I mean, I didn't know until I went. So people may not know, but as I've told my students in public health, they're getting there for every one of my students whose parents or grandparents or siblings said, "What are you doing?" I mean, I think we're all getting a really fast, difficult lesson in what public health is. It's challenging, right? So public health is the study of health over time, and for all of us, and particularly looking at things that affect people broadly, and that's what public health studies. But specifically within public health, you can look at lots of different things. So epidemiology is one area you can study, which looks at history of diseases and their rates over time. Biostatistics specifically looks at the data as it relates to public health. My area is health policy and management. So in addition to epi issues, I'm also interested in the way in which policies and laws and regulations impact on healthcare, and or, as we saw today with Governor Cuomo, how laws can be implemented to deal with a public health issue. But these are all areas in the realm of public health. So, when we think about specifically epidemiology and biostatistics, those are the two tools we would use for Lisa's question. So I see what you're saying about but the numbers are skewed. I don't think about it as skewed so much as that we're not, the data is only as good as how much information we are able to gather. So you would have to believe, you've got to believe that there are way more cases than we have. So when you see 7,102, I mean, there's a lot more probably than that. What's a more sort of interesting number is if we look at the number of people tested and then we find what the cases are there. That gives you a little bit of a better percentage of then being able to figure out from a statistical perspective how many people in the country have it based on that. So in terms of, does it seem very skewed? I gather, and we can talk about it when we get off. I would imagine that what you're conveying is that you feel that there are more cases than what are being reported. That absolutely has to be the case just by virtue of the fact of who's being tested and how many people are being tested. Clearly, the best way to know how many cases we would have of COVID-19 would be if every single person in the United States were tested. Then we would know from that the exact numbers down to, the exact people. Now, what is the problem with that? Well, the problem with that is, one, the capability of doing that, both in terms of resources and in terms of people. How many people do we have that are trained to be able to do that kind of testing and can actually do it? We, more likely than not, do not have enough people to be able to do that testing in order to do that. And clearly, as we've all heard, we don't have enough kits. So all that number is telling us, the 7102, is based on the number of people that have been tested, how many of those people actually have the disease? But that's what that's telling us. So make no mistake, the numbers, the 7,102, I 100% guarantee you, I 100% guarantee you there are not only 7,102 cases of COVID-19 in New York. That is not true. But of the people that have been tested, those are the number of cases we have. And so it starts to give you a picture, not so much of what the true representation is, but rather, to my mind, it actually gives us a better indicator of why something like social distancing is so critical. Because if that's a fraction of what the cases really are, and to be honest with you, some of the evidence suggests that it's more like 6 out of 7 people. So if you tested, well, let's not become alarmist, but there's a lot more people that have COVID-19 than 7,102. That is for sure. And so in terms of skewed, it's only skewed in as much as the testing is not happening. And so we can talk about that when we open up the questions. And so yes, it is technically underreported, but it's not underreported in the same way as other diseases would be underreported, because this is underreported because legitimately people who we know probably have the disease have not been tested. And this goes into another issue, which goes back to the ventilator issue, which is once people are tested, what at this point is going to be done for them? And that is a little bit of an open situation depending on how long this goes on and what this looks like. And from a legal standpoint, what can be done. And so that's another issue in terms of once people are tested, what will happen for them, let's say a month from now. We can definitely talk about that for sure. Okay, So this is from today. So has anybody heard about pause? Anybody know what that is? We're going to talk about it in a second. Had anybody heard about it before you just saw it on the screen? Okay. So pause stands for Policies to Assure Uniform Safety for Everyone. Now, as Governor Cuomo noted today, this is not a shelter-in-place order, but we're going to talk about the parameters of what it is exactly. And I spent the better part of my afternoon essentially transcribing the governor's press conference today and then doing research on this and also doing research on the executive order that was released and also Matilda's Law, named after his mother, which I'll go into detail about. But yeah, for somebody who said the New York City has moved to a different phase in pandemic response, well, here you are. Here we go. that move happened at about 11:35 today. So, first of all, according to the governor, this is not a shelter-in-place order. And as he stated today, shelter-in-place refers more to things like active shooters, school shooters. And so this pause, which takes effect on Sunday night, has some very, very particular parameters, which we're going to go over, and which if you do not follow them, there can be some consequences, which is now going to be an issue. Okay, so pause in action. So pause is 100% of essential workers must stay at home. Non-essential businesses must close. New Yorkers over 70, actually, it's 70, must remain home for solitary exercise, wear masks in the presence of others, and check temperature of any essential visitors. To continue with that, non-essential gatherings of individuals of any size for any reason, for example, parties, celebrations, or other social events, are canceled or postponed at this time. Any concentration of individuals outside their home must be limited to workers providing essential services, and social distancing should be practiced. When in public, individuals must practice social distancing of at least 6 feet from others. It goes on. This, by the way, is for non-vulnerable populations, okay? So we will get into Matilda's Law, which is for vulnerable populations, in a moment. But this has to do with non-vulnerable populations. To continue, businesses and entities that provide essential services must implement rules that help facilitate social distancing of at least 6 feet, okay? Further, individuals should limit outdoor recreational activities to non-contact and avoid activities where you come into close contact with people. And Governor Cuomo spent a decent amount of time on this for anybody that is unclear as to what exactly that means. And we will get into that in a moment. Individuals should limit use of public transportation when absolutely necessary and should limit potential exposure by spacing out at least 6 feet from other riders. So if you're going to be on the subway, you need to be 6 feet from the next person that is on the subway. Outdoor recreation, what does it mean? I just thought this was really interesting because that we have to explain this to people. It's fascinating to me, but apparently we do. So according to the governor, and this is a direct quote from him, outdoor recreation is a solitary recreational exercise. Running, hiking, not playing basketball with 5 other people. That's not what it is. It's not laying in a park with 10 other people and sharing a beer. There's certain places in New York where it looks like life as usual. It's not life as usual. Let me reiterate, it is not life as usual. And he's absolutely right. Playing basketball with 5 other people is not what he means when he says outdoor recreation. and it's not a solitary recreational exercise. So when we think about what that looks like and what that's going to look like over the next several weeks or months, that's what that is. Matilda's Law. So this, again, went into effect 11:37-ish today. Matilda's Law specifically refers to the most vulnerable groups. These are seniors over 70, the immune-compromised people, and those with underlying illnesses. This is today, well, technically, this goes into effect this weekend. So please listen carefully if you are in one of these groups. It applies to you. So if you are 70, if you are immune compromised, or if you have a serious underlying illness, this is what you need to do. And by Monday, this will absolutely be in effect. Number 1, you must remain indoors. Number 2, you can go outside for solitary exercise. What we described, not basketball games, not, you know, in a park with a bunch of people wrestling or anything like that. Solitary exercise. Number 3, you must make sure that all of your visitors are pre-screened and that aides, those visitors and aides are pre-screened, and they do that by taking their temperature. So if you have an aide that comes to help you and you are in one of these groups, they must take their temperature before they can care for you. You should not visit households with multiple people. So if you have a friend that's got a bunch of children and their grandmother lives there and their uncle also lives there, that is not a place you should be going under Matilda's Law. Next, vulnerable people in this category should wear a mask when in the company of others. Next, to the greatest extent possible, everyone in the presence of vulnerable people should wear a mask. So the vulnerable people should wear a mask, and the people in their presence should wear a mask. Additionally, they should stay at least 6 feet away from individuals. And finally, they should not take public transportation unless it is urgent and absolutely necessary. I will make this available to you. This is also on the governor's website. You can find information there about it. And I highly recommend taking a look at his press conference from today, where this is outlined as well in a decent amount of detail. So this is Matilda's Law, named after his mother, and it applies to the groups that I just described above. Okay, so it's 6:44. You know, future webinars can include some of what I have here, and, you know, including things like what quarantine actually looks like, when can I get back to my regular activity. So feel free to email me. I'm going to be doing webinars on a regular basis. And these are some references that you can utilize. And I think at this point, I will take some questions. Sarah, do you want me to take people off mute? Hello? Hello? Oh, hey.
Oh, hey, Heather.
Hi, we meet again.
Yeah, great. I enjoyed your presentation. I was actually gonna ask you if you could just email me the slides on a separate note. If you want, I can maybe put my official email in the chat, because I do have a, my dad fits the age, vulnerable age, and I want to see what he can do, despite he's not the most compliant person, but that's just on a separate note.
Well, he will need to become a little bit more compliant now. Now, here's the interesting thing, though. So the Jacobson v. Massachusetts case I mentioned before, the Supreme Court case from 1905, that case actually did have sanctions for people who did not comply. right now, there are no obvious sanctions for people who don't comply with Matilda's law. But I suspect that as we go forward, we will see a different environment in terms of that. And the governor is within his rights to be able to ramp up what that looks like. So, you know, he already mentioned on the webinar that I saw, the press conference that I saw, being perturbed by what he saw as life as usual in certain parts of the city. If that continues, then I would imagine, and if there's lots of people that are, you know, 84 years old that are roaming the streets and not complying, then we might move to a different set of circumstances in terms of legal sanctioning. But for now, essentially, the law, once it is fully in effect, basically applies to people abiding by these rules.
Okay.
But I'm happy to send the slide to you. And
Absolutely.
yeah.
I could give you my email right now. I think Sarah's trying to say something, so let me just give it to you quick.
Okay.
It's Lou. Oh, hey, Sarah.
Hi.
It's Lou. That's Lou.
Okay.
Dot PANICCIOLI at gmail.com.
Great. I got it. I'll definitely make sure you have it.
Great.
Okay. Are there any questions?
So I see, Heather, in the chat that it was shared that there were 2 fatalities on Staten Island from the coronavirus. I wasn't aware of that. I don't know what the source is, but definitely our prayers go out to the family. But it is a reminder about how serious it is to comply with some of these recommendations.
Yeah, that, and also, I mean, you know, I didn't get into sort of the you know, minutia of the science behind this, but you know, remember that this virus started out one way and it looks very different now. And so to the extent that it's mutating and it's changing, the virus is, it's going to look very different in a month than it looks now. And we don't really know what that's going to look like. And also just to remember, you know, a virus, the example I always use is a carbon copy, how a virus is essentially a carbon copy of itself. So it's not precisely exactly identical. And over time, it can change, and then you have a mutation, and then it changed drastically. So this notion that what we know about COVID-19 will stay how it is forever is not accurate. And I think maybe that's what's giving people a false sense of security, but it's not really accurate. That's not to be hysterical or scare people. It's just to say that it's catastrophic. And for those people who were impacted, and for the 2 people in Staten Island who passed away, which is horrific for everyone concerned, it's something that absolutely should be taken seriously, because there are deaths, and we've seen that. Absolutely. The only other thing I wanted to say before I take any more questions is, if you can't sort of wrap your head around COVID-19 for yourself, and you can't even wrap your head around it for your own family, then what you should do is think about it in the larger context of our health system. And that's the main thing that I study, are health systems. And so when we think about the health system and whether or not it can sustain thousands of victims of COVID-19, the answer is no. And so to the extent that people can safeguard themselves so that they don't get this disease, then that safeguards the system from being overloaded, which is not something, I guarantee you, it's not something that we want to see.
I do have one more quick question, and I'll pass it to other people that have questions. I've been hearing a lot just in the community where people think that because they had the flu or because they have been sick, that they are somehow immune. or have a strong immune system, or if they have large quantities of vitamin C, they can help boost their immunity so they won't get the virus. So they are going out even though they are symptomatic. Can you talk just a little bit about what makes this virus so different from other viruses, and a little bit around like why those are myths?
Sure. So in terms of the difference, there's a couple of things. So one, and again, you know, if I say something, I'm a research person in addition to my administrative job, in addition to my teaching job. And so what I'm conveying to you is from a place of research, from a place of studies. So there's two studies that have caught my eye over the last few weeks, and you may have heard of some of this, actually three studies. So one study has to do with, and this is actually a pretty interesting one, a blood type in COVID-19. So it appears, unclear why, but it appears that people who have type O blood are exhibiting signs of COVID-19 at lesser rates than people with type A blood. It's interesting. Now, is that causation or correlation? That's unclear, but that's an interesting study. With the second one being scans of people who have had COVID-19. So, you know, whenever we have a disease and it involves some sort of a inflammatory process, you can have damage. And people with COVID-19 or some of them are exhibiting some really disturbing damage to their lungs on CT scan post-disease. And now what is that from? It could be from the inflammatory process. It could be from, you know, having a virus running rampant through your lungs and then the outcomes of that. But something about it looks a little bit different than what we see with people who recover from the flu. And also it appears that there's some lessening of airway capacity with these folks. So that's another thing. With the third one to my, so there's another interesting, so I add this as fourth, another interesting symptom, an early symptom is diarrhea. So apparently now people in China are disclosing that they were having GI symptoms before they had any other symptoms. That's really interesting, because that might be sort of the sort of the canary in the mine, so to speak, before these other symptoms. So if you start exhibiting the respiratory issues on day 6, maybe on day 1 or day -3, you had diarrhea. And so it appears that might be another symptom. With the fourth study, which is of most interest to me, is a study, and I can give you links to all of these. The fourth study is a study from a group of researchers at Princeton that seems to indicate that the virus that causes COVID-19 can actually live in the air for 2.7 hours. Now, to put that in context, measles can live in the air for approximately 2 hours. Now, nobody is saying that it's an airborne disease of the level of measles, because, I mean, measles is extremely penetrant, extremely. But what that does suggest to us is that there's something to note about this disease with respect to how long it lives in the air, and we should pay attention to that. So those are the 4 studies that I noted of interest, and those are just a few examples of why I would say this appears to be different than what we think of as a seasonal flu. Does anybody else have a question? Natalie, do you have, hi Natalie.
Hi.
Hey, it's nice to see you.
And you too.
Yeah.
I would have made everybody dizzy. I was walking around the house a lot, so
Okay.
I just muted and put the video off. I'm outside now, so if you can't hear me, I'll go back in, but I'll just have
You're
to find
perfect.
my spot. Okay, great. So I have a concern that I believe is a realistic concern, and that is what we're gonna see as the healthcare system gets overtaxed and overburdened.
Yeah.
We're going to see a lot of conditions that are serious unable to be treated in a timely fashion. So
Non-COVID-19 conditions.
correct.
Yes,
So if
I agree.
somebody in a few weeks time, maybe a couple of weeks time, however long it takes for the hospitals to get overrun, somebody is going to have a stroke and get emergency attention for that stroke, but not in the kind of timely fashion they normally would, and that person is not going to make it. Same with a heart attack. So I believe that is a reality, and I hope that eventually that message gets out in a delicate enough way that anybody who has the capacity to better manage whatever it is that's going on normally with themselves is taking extra care. But that brings me to the maternal mortality issue. And we know that Staten Island's maternal mortality rate is egregious. So this isn't a discussion for this moment, but I'd love to reconvene at least with a handful of people about who we can bullet point alerts to about giving an extra heads up. We already have really shitty outcomes where it comes to that stuff. And in this time of crisis, we may see even more situations where women will die post-childbirth and during childbirth. And if that's in any way preventable because of like unconscious bias or attention to complaints, now is the time more than ever that we have to be able to remind caregivers that it's just critically important.
Yeah, I mean, I agree with everything you said. You know, we're gonna get to a point where, I mean, I can't believe in my non sort of historical look at public health. I'm using this term, but when we think about rationing, that is a realistic term to start using, and what that's gonna look like. And then, you know, I would say the rubber's going to really hit the road in terms of what we care about as a society and who we care about. And then we're going to start to see in stark reality what that looks like. And so I would say, you know, before we get to that level, we need to sort of think about how to advocate for those individuals, including the population you just described, because you know, I talk about rationing theoretically in my public health law class and in my bioethics class. I'm not talking about it theoretically anymore. Or I should say, I used to talk about it theoretically until a week and a half ago, but I'm not talking about it theoretically anymore. And so I think to the extent that we focus on that and we deal with that, and we look at like the specific populations that are going to have these issues, I think it behooves us to do that.
Yeah.
There was a comment up further that had to do with sort of just like basics in terms of people being exposed and quarantine and so forth. And my comment to that is, yes, I think we should all be under the assumption at this point that we've all had some sort of exposure to somebody that has COVID-19. I mean, I think that's just the reality of it at this point. I would say we all need to go under that assumption. And again, you know, in line with Natalie's comments, and again, I study healthcare systems. It's what I do. And so to the extent that the system is not going to be able to absorb all the people, obviously, that have been exposed, it's not going to be able to absorb all the people that become ill. It's not even necessarily going to be able to absorb all the people that become critically ill. This word, again, in terms of like what that's going to look like and what kind of care different people will get, is something we really need to start thinking about. And so if there are specific groups that people on this call are concerned about in terms of what kind of advocacy they have or what kind of care that they will not get, now is absolutely the time to be able to be thinking about what that's going to look like, because that is going to become decently critical really quickly in a very short amount of time. And so, you know, I can't tell you what your organization should do or should not do, but I would say that if there's specific groups that you are concerned about, now would be the time to start thinking about how you're going to advocate for them, because it's just all moving so rapidly. And so that's what we have to think about. Somebody else wrote something about people that are living alone and are being told by their doctor to stay home because they are not in serious enough condition to be in the hospital, but they are sick. They need to have people checking on them. Mary Hernandez, I totally agree with you. The sort of sub-issue that you're dealing with has to do with how do you check on somebody who is sick and may have COVID-19 in a way that protects yourself and make sure that you yourself don't get ill. And, you know, I'm going to do a webinar probably next week on what it looks like to live with somebody who is quarantined and what it looks like to live with somebody who is in isolation. And one of the things to think about is, you know, when you're in isolation, you really shouldn't have free reign of the house. You should have an area that is your area. It could be your bedroom, it could be your guest room, and then there should be somebody designated in your household to take care of you. So if there's 6 people living in your household, all 6 people should not be helping to care for you. And that's everything from, you know, laundry, for example, and how your clothes get laundered and who launders them if you're very ill relative to the rest of the laundry in the household, and who's going to actually be able to do all those things for you. So for Mary Hernandez's comment, I think you're absolutely right. And the concern is going to be for people who live alone and then they become ill, who will do all these things for them? And I think we need to start again thinking about that from an advocacy standpoint and thinking about who will do their laundry, who will cook for them, who will help them in terms of supportive care, who will, if necessary, eventually get them to the doctor, how will they transport them to the doctor? So these are all things that we need to be thinking about collectively and looking at, because the healthcare system essentially is going to be hard pressed to be able to manage a lot of this. And so it's going to fall on other people, for people who are live by themselves and are alone. And then we have to look at what that's going to look like. I've been advising people to close their toilets before they flush. The studies have shown the virus is stool for 27 days. Yeah, well, as an aside, you should always close your toilet when you flush, because when you flush, and this is kind of disgusting, but when you flush, actual fecal bacteria gets up pretty much everything in your bathroom. So if your toothbrush is like sitting anywhere open in your bathroom, that's not wonderful. So you should probably like get anything that you care about away from the bathroom when you flush, because the fecal matter actually goes everywhere. And so, yeah. How long do you estimate the pause will last? That's so hard, but you know, I take my, actually it's interesting. I think I mentioned I went to Princeton University, and today they haven't canceled commencement, but they canceled their like big reunions that they do every year, which is the end of May into early June. That puts us at 2.5 months out. And if you notice now, a lot of graduation ceremonies are being canceled, and you know, a lot of students are being told you probably won't be on campus until September. So I think that's giving an idea about this. And the other thing to think about with a pandemic like this, and again, we saw it very cleanly with 1918, is these things don't just happen and then it goes away and everybody goes back to life as normal. And I think everyone should pay extremely close attention to Italy and to China, because that's going to be very interesting to see whether or not they have recurrences. The pandemic of 1918 went on through 1918 and 1919, and that's because you had essentially rolling outbreaks, rolling epidemics. where there would be sort of a pause in what was happening, and people would get better, and then you know, a couple of weeks later, you would have another uptick in cases. So I would be very happy as a public health person if this just played out, that we had no more outbreaks anywhere in the world, but I'm loath to believe that that's going to be that seamless. And I would say that this will be with us for some time to come, and there will be hotspots in different areas, and you might even see recurrences in the same place where you saw really horrible outbreaks 6 weeks before. So I think the pause is going to be for quite some time, mainly because it's not going to be just you had an outbreak in this area and now you're done and you can go back to living your lives. That's not really exactly how a pandemic of this nature would work. And so we just need to all be vigilant. But I would look very closely at places like China and Italy to see if they have any upticks in their cases in the next few weeks. That'll be a bellwether moment for us. Yeah, 2 weeks, no contact, 2 weeks, not symptomatic. Is it safe to go outside and practice physical distancing, to shop and walk around, or should I continue to shop? Well, that is a very good question, my friend Roxanne, because more so than you're wanting to do that or not, it's going to be what's in place from a legal perspective. That's our handy public health law. So you may want to go back outside and start living your best. I don't mean you. I know how you are. So you're a careful person. But an individual may want to go back outside, living their best life as they were living it, you know, sometime in January. But the law may not allow you to do that. Now, again, it's sad that we necessarily need laws to make sure that people stay in their homes and don't go outside and don't play basketball in the parks and so forth. But apparently we do need that, since the message isn't getting through to everybody that they need to be socially distancing and not be out on the street corner hanging out with their buddies and having a party and so forth. So unfortunately, because of that, we now have Matilda's law and we have an executive order. And to be honest with you, we will probably have other mandates that are put in place if people do not abide by the executive orders that the governor put into place today. So no, I would say that that won't be the case, and I would be very surprised if 2 weeks from now this is lifted and we're told we can just go back to our regular lives. That would be very surprising to me. I don't think that'll be the case. So it will probably be with us for some time, and we will have to just all sort of watch and see what happens. Right. If I after 2 weeks, I'm not symptomatic, do I not have COVID? I would say that's not something you can absolutely say 100%. And actually, you definitely can't say that 100%, because even though the vast majority of cases exhibit after 14 days, not all of them do. And because we're still gathering research on people and the manifestations of the disease and the rates of the disease relative to when people have been exposed and what that looks like, and so much is unknown. Well, so much is unknown. We're still studying people who were only a few weeks out from having had the disease. And so getting more information on them and what their outcomes look like, it's critically important. And the other sort of thing I would say is, a fair amount of people who have this disease, after they have it, they don't feel so great. So you have, having 2 weeks and then not getting the disease, and then saying to yourself, "Oh, I'm free, I'm okay." The percentages don't bear that out absolutely. Although after 14 days, it appears there is a very good chance that you won't get disease, but we don't know that to be 100% true. And again, it's not 100% true. And the disease is changing. And so what the disease will look like in May I guarantee you it will be different than what it looks like now. And it may be doing different things in May that it's doing now. So we can't say what it'll look like in May. And since we can't say that, we can't really say what it will look like for you if you know, are trying to be out there living your best life after 15 days. I know it's an anxious time for people, and I know that it feels very much unsettled, and it feels very much like people want answers. The sad part about this is that we have some answers, but they might change. And the other answers that we have, we know them to be true now. We don't know that they will be true in a couple of weeks. And so that's why we've got to be vigilant in terms of protecting ourselves and our loved ones and being very, very up to date on what's going on, which is why, where you can get information that is excellent, for example, getting updates from elected officials who will have some information that is critical. Any other questions? Oh, yes. Celia, you want to ask a question? Celia, you want to ask a question? I don't know how to get you off of. Yes,
I took
Celia.
myself off mute. Can you hear me?
Oh, great. Yeah. Hey, how are you?
Hi. How are
Sure.
you? So I just want to make a couple comments first. So I work at NYU. I'm a nurse practitioner. I work in outpatient, and I just wanted to comment that I was really struggling with this. Like the last 10 days, we were still seeing patients. We weren't being told to transition to telemedicine. And we weren't giving masks. So
you were not given masks.
We were not given masks. In the outpatient setting, it was only if there was like a confirmed exposure. There was nothing being done to prevent us from transmitting or potentially somewhat protecting ourselves. Although I get it, surgical masks, we're not talking N95s.
Right.
So what concerned me, and I think now we're doing a better job of transitioning people to telemedicine visits who are not urgent.
Yeah. But
I feel like that happened too late. Yeah. And I strongly suspect that I and my family are now exposed. I've been hearing a lot of talk about GI symptoms, and that's what our daughters had for 2 days. Now my husband and I have, and I woke up with chills and just a bunch of things, and I'm starting to get a fever. No cough, but I know that will probably come.
Happen, yeah.
And so I just hope, I guess my concern is there going to be something done about eliminating these non-urgent visits?
Yes, that happened today.
Okay, and so today of all day, like I've been watching everything, but today I missed the governor speaking.
It happened today. Elective procedures are going to be basically done. They're going to be really quick.
Does that include like non-urgent visits where you're coming for an annual follow-up and you've got nothing new going on and you still have this option of coming in person? Is that something?
I'm looking at my notes. Let me look at my notes. I believe that I will check on that and make sure, but he indicated pretty strongly that non-elective procedures are suspended until further notice. And that definitely applied to elective surgical procedures, and other elective procedures. So if I look at my notes, that's what I wrote down. And so I'm assuming that would basically be certainly the surgical procedures. And I think telemedicine is going to take over for a lot of procedures. But I will find out the exact ones that he was talking about. There will be by Monday, there will definitely be a change though, in terms of what procedures are going to go forward in the hospital.
Yeah, and then another question I have you heard anything about Pepcid being useful?
For the GI symptoms?
No, maybe to calm down immunity, like immune response. I'm not really sure. This seems to be an emerging thing. And then also increasing capacity of ventilators, since
he talked about the ventilators. I had mentioned that a little bit before, but the ventilator issue, essentially, there's basically there's just not many of them to find. So they put a call out to
Right.
The health department in the state, and actually he mentioned too that there are New York State officials in other countries that are trying to purchase ventilators.
Right. What I mean is there was talk of taking a vent and making it useful for 4 people, up to 4 people. Do you know if that's still something that's being considered? Because so what I've been told is that at my hospital, we're at ventilator capacity.
Yes.
And it's March 20th.
Okay.
I've heard Northwell, if they're not there, they're going to be there any second.
Right.
That's horrifying.
Yeah.
Northwell is a big hospital system. NYU has many hospitals. I don't know if it includes only Manhattan, but that terrifies me.
Yeah.
So
Northwell is huge. Yeah, Northwell is massive. I wrote that down. One that was not mentioned too, I would be really, that would be surprising.
I don't know how safe that is. That's why I was wondering if you had heard anything.
No. In fact, on the call today, I mean, there was no mention of that. And in fact, there was a mention of continually looking for more ventilators because of the ratio of current ventilators to what is needed. And there's a discrepancy in the thousands, which I probably don't need to tell you that, but it's thousands of ventilators that are needed versus what is actually available. The number he threw out was 3,000 that are available currently, and the need was, let's say, the quadrupled. Need was a lot more than that, like quadruple that. So that's interesting, your number, the times 4 number, because that was almost the number that was thrown out there in terms of the need versus what's available.
I think it was a Canadian who had maybe figured out a way to increase capacity of one vent. But yeah, these are just things that I've been hearing about. So
right. Well, Celia, I mean, I don't know you. Like, my thoughts are with you. They really are. I'm so sorry.
Yeah.
And
it's okay. Look, I'm glad I have it now. If I have it, I don't know. I mean, I don't know if I have it, but I feel like I have it. I feel like it's early. You know, let's hope we're in that 20%. So that's my, I'm just keeping fingers crossed. So.
Yeah. I mean, you know, the one good thing about getting it earlier is I mean, there's still services available for you to a certain extent, as opposed to what we might be faced with if we don't get this more under control in another month or two.
Plus, I think for some healthcare workers, get it over with. Maybe you get it again down the road,
right?
But you had it, you recover. Now you can help relieve everyone who's overburdened. I mean, it's what's going on now is it's insane.
Right, which, you know, as somebody who's a helper like yourself, of course you would say that. Everybody else is like, keep it away from me. No. So of course you're a lovely person and a helper, so of course you would say that. But you know, a lot of other people are trying to figure out ways to, you know, get all the Purell and ramen noodles they can and hunker down for the next 4 months. So
one last question. The masks that are going to these susceptible old elderly, how are we getting masks to them?
So you mean practically how we're getting them to them? Well, that what you mean?
Yeah, they're not available.
Right.
Healthcare workers. I've been given one mask.
Right,
I have to use it for days.
Over and over.
Yeah.
Yeah, I know. That's the word on the street. That practically I don't understand it. From a practical standpoint, it's, you know, and again, I mean, this is the other interesting thing, right? We're starting to learn a lot about where our things come from. And a lot of our medical supplies come from, wait for it, China, right? So, you know, because they're dealing with so much heartache and so much hardship, it's starting to become very apparent to us that because they're dealing with that, it's getting increasingly difficult to get things. And so I don't practically see how that's going to happen, to be honest with you. I just don't.
Yeah. Well, thank you very much. This has been really informative. So appreciate
it. I'm glad. Just take care of yourself, okay?
Oh, thanks. Try.
You're welcome.
Okay.
Are there any other questions? I went over a little bit. Oh gosh, it's 7:20. I'm sorry, everybody. It's 7:20. I guess I will probably Sarah, do you want me to take any more questions or I don't know, Sarah, are you still there? Sarah. Okay, well, what I will do is I'm going to make this available. I hope you found this helpful. I hope I was able to help individuals, and I'm going to make my PowerPoint available. And I think I told you I run a nonprofit, so we're going to be doing these kind of sessions as long as this is going on, and we do other things. So I'll make that all available to you too. And in fact, I'll type the nonprofit information. Oopsie, I'll type it in the chat, and feel free to. I'll also actually, I gave you my email. I will also give you my cell phone number, and the name of the nonprofit is H.E.A.L.T.H, and we're at Health for Youth on Insta and Twitter and so forth. So feel free to reach out. Sarah, what else? I know you wanted to give some announcements at the end. I hope everybody found it helpful, and please be in touch with me.
Thank you so much, Heather, for doing this webinar for us. We are just really, really so grateful. And I don't just speak for all of the people that were attending right here live, but all the people that are going to get the recording and really benefit from this information. Staten Island Women Who March is going to share your information about your nonprofit on Staten Island. For everyone who's not aware, like she said, Heather is the executive director and founder of Health for Youth.
Yes.
She also does a lot of the gardening on Staten Island, and all the little free libraries that you see all over parks and in front of schools and police departments. Heather's also responsible for that, and so much more. So we're going to be sharing out your website. We're going to be sharing out your contact information to all the SWIM members, and to really continue to partner with you to have more webinars around COVID-19. And when anybody has questions, feel free to email any of the core at SWIM. Feel free to email Heather. We're going to keep these webinars coming to you, and make sure if we see other webinars that Heather's doing, we're going to email you guys. We have your contact information. And I also shared SWIM's website. It's in the chat box. I'm Sarah at swim.org. Roxanne is also on the call. Roxanne at swim.org. Stephanie is also on the call. Stephanie at swim.org. There was a few other resources shared on the chat, some lactation consultant resources. So if you're pregnant or you know someone who is expecting, you can share those resources as well. So thank you so much. Everyone be well, be safe, wash your hands, practice social distancing.
Thank you, Sarah.
Thank you, everybody. I'll be in touch, okay?
Okay, don't forget to shoot me the slides. Thank you so much.
I won't, I promise. Bye.
Bye.